Zoom recording. Good to go. And we got everybody. You can turn your cameras off if you guys want. Push the button.
Okay. I want to say I hope people leave their cameras on. I want to see people.
Uh,
Can I say that?
yeah,
Yeah.
no, you say whatever you want.
Yeah.
All right, this is the Denise show. All right, I'll keep letting people in as we go.
Okay.
All right.
All right. Well, we're going to get started. My name is Heather Gates, and I am a parent of a 27-year-old daughter with AHC, as well as Vice President of Education and Family Support for AHC Foundation. I'm going to let Denise do her own bio, but thank you, Denise Potter, for being here and sharing with us today.
Hi. Thanks so much, Heather, and thank you for having me. I'll just tell you a little bit about me. I'm a registered dietitian. I'm a mom, not of an AHC child, but just a mom, because I think that also tells you a little bit about where someone comes from. I've been working as a dietitian for over 30 years and in keto for almost 20 years now. I started working in ketogenic therapy just at University of Michigan Hospital as a piece of my outpatient position. And that grew into more of a program where we worked with a lot of kids, with mostly kids and then adults with pediatric epilepsy. And then it kind of grew to other conditions. And then over time, people started calling my office at the hospital and saying, can you put usually at that point it was my family member on keto, they have cancer or they have another condition or they have migraines or we can't find a dietitian. And so I started sneaking around seeing people at McDonald's or wherever and just started a little private practice. And then just over time, the need for people to do ketogenic therapy outside of that hospital where they had epilepsy, if they didn't have that, they couldn't be seen. And so I just kind of grew into doing my own thing on the side. And then that grew into me leaving the hospital and just forming this AKT that you see. So I'm not here to sell you services. Just here to talk about keto, what it looks like for people, um, what it is and what it isn't, because I think you can have a lot of good information and then a lot of misinformation about keto for epilepsy and for AHC. So one thing I do want to make super clear is that this is in no way me giving medical advice. Okay, that's just a huge disclaimer saying that anything I say, these are opinions, professional opinions based on experience, but just anything that I might say or recommend to look into is not medical advice. It's just for you to take to a provider. And we always recommended that a ketogenic therapy is done with a doctor, with a registered dietitian. So I think that's enough to start. And so what I really want to do today is field questions. I mean, I have, I guess I'll start. I'll tell you a little bit more about keto, just in general, in case a lot of you probably have some background, but just in case you have no background on ketogenic diet or ketogenic therapy, kind of use that interchangeably. What it is when we eat a very high fat diet in order to put our body into ketosis, which means you're mostly burning fat for energy. And think of it like a hybrid car. I used to have a Camry. It was a great car. Loved it. And it could run on battery or it could run on gas. And so think of yourself like a little Camry. God created us to either be able to run on carbs, fat, or protein. So you can run on any of the above. And in the absence of a lot of carbohydrates, your body will start burning fat for energy. And they found keto as a treatment because they were fasting people for a period of weeks. And after several weeks, a lot of people stopped having seizures, but of course you eventually have to eat again. And so they thought, how can we copy this? How can we let them eat but still make ketones? And they realized if we got the percent of fat high enough, then the body mostly would run on ketones. Still runs a little bit on sugar or glucose, but largely on these ketones, which are the byproduct of fat breakdown. So when we put someone on a ketogenic diet, we're trying to hit this high percent of fat, really low carbohydrate. And so that being, I know it's probably super obvious, but for anybody new, fruit, bread, pasta, rice, potatoes, those being in dessert, sweet sugar, those are your big carbohydrates. So very, very low on that. And then moderate on protein, not a low protein diet, but an adequate protein diet. So those are kind of the background generalities about keto and what's going on with metabolism. We're trying to keep people in that state of ketosis. And when we do that, that gives the brain a different fuel source. And in epilepsy, it's 50 to 75% effective at stopping seizures. When I say effective, when they say a medication works for epilepsy, they mean it helped 50%. So if you have 50% fewer seizures, that's a great medicine. The diet is even more effective than that in a lot of cases. And in the case of epilepsy, it's more studied than any of the drugs and medications that someone would put their child on. And that becomes super relevant here because we know that a lot of kids with AHC also have epilepsy, and maybe it was confused for epilepsy at the beginning. So you have these co-conditions, and then we've seen enough benefit with people with AHC, even without epilepsy, that sometimes because it's the neurological component, this diet sometimes can help. So we see, and not just in epilepsy now, we're seeing people with almost, I won't say any, but I'm just going to say almost any neurological condition have some benefit from keto for that. So we have neurological conditions like mental health conditions like bipolar, schizophrenia, migraines are very impacted. A lot of cancer is a whole different topic, but there's just a laundry list, MS, of conditions that we see improvements with this type of therapy. So I think I kind of want to stop there. I would love it. I know people are probably at all different places, but if you can turn your camera on, I would love it because I'd love to see faces. If you can't, I totally understand. And we're going to take questions. I think if it works out well to have people just ask the question, you can raise your hand. We'll call on you to just ask your question. We're going to ask you to try to keep the question to 30 seconds or less. If you go on too long, Heather's probably going to interrupt you and say, "Oh, get to the end of your question." And I think we have plenty of time, and we just want to see what kind of engagement. I have things that I can tell you about keto, but I want to see what questions you guys might have.
I got a question I'll ask.
All
right. A lot of these kids have trouble chewing. How do you make, just going to say steak, more easy to eat, I guess?
Okay. Well, you can do it for them. So, sorry, this is me trying to be funny. Okay, well, if they have problems chewing, they're eating something, right? They're eating non-keto something. So you're either probably
they're all eating all the breads, the pizza,
Okay.
Like
yeah. So if someone needs, let's say, a chopped or a blended diet, then we can do a keto diet that way. And steak, of course, is super chewy. I mean, maybe they never eat steak. Maybe they eat ground beef because that's much easier to chew. I'll say, and this is a fun fact, just since you mentioned the chewing. I know with some kids with AHC that, having a smaller meal is actually beneficial because it takes so much energy to eat. And a ketogenic diet actually is a smaller volume of food because the fat has so many calories that when you do a lot of the the portion of the diet is fat, the volume is down, and now they have actually less food to eat at the same calorie level. Does that make sense? So anyway, so as far as texture, yeah, we can adjust the texture. We actually can do, honestly, any texture you need, any allergy that someone has. We just avoid any foods that are allergens. So we can do dairy-free, we can do vegan, we can do vegetarian, we can modify keto in all those ways. Does that help, Bill?
Yeah.
Yeah.
I'm trying to figure out how to get them off the pizza.
Well, here, let me give you, just as a mom whose daughter's been doing keto for I 4, 5, something, 4 or 5 years. I can't remember now. She can't ever choose salads, meat, things like that. So she does have a G tube, but she eats half of her food and gets the other half in her G tube when we do a blended keto, formulas, or Denise has created some. We use Denise to consult. But we do batch cooking, and she can eat softer things like cheddar biscuits, pancakes, things like that. They're keto and they're her ratio. And so we do those and then just weigh the food. So, and there's companies that have pre-ready food, and one of them is little tiny pizzas.
As little
And
pizzas, yeah.
yeah, and she loves them. And you just put them in the oven and bake them, and bam, there you go.
Oh, they make keto pancakes. He has pancakes
Yeah.
every day for breakfast.
Yep.
What is
She
a
has her
keto
pancake.
pancake? What is it made out of? Matzah?
No, eggs, a lot of eggs, cream cheese, almond flour.
Mhm.
And then if it's not quite the ratio, like Denise will say, add butter or oil.
Mhm. And when she
Oh.
says ratio, just to clarify for people, we either think in terms of what percent fat is the diet, or ratio of fat, fat to protein and carb. And that's just something you work out with a dietitian. But if it's not enough fat, we might have this pizza and like, well, it's kind of high fat, but not high fat enough. Then we're gonna add a little fat to it to make it be keto enough per that person's ratio or their needs, because we know we test ketones and to see how effective is, and I'll say how effective the diet is, to make sure we're in a level of potentially producing effectiveness. So we can measure ketones in the blood or in the urine, but we prefer blood, to see if it's going to have a chance to be effective.
Adriana had a question. The higher the ratio, the better outcome for cognitive results.
Not necessarily. The higher the ratio. So the ratios go up usually to about 4-to-1, which means about 90% fat. And that's really hard to eat. Okay. So what I tend to do, and I'll tell you, what I did 20 years ago and what I do now are two different things. Okay. We used to put everybody on a 4-to-1 ratio, and it was really hard to eat. And not a lot of people, but enough people just couldn't do it and really hated their food. So we work our way up to a level that gets us the ketone numbers that are good for that age, because age matters for ketones. A child can get better ketones than an adult usually. And we measure cognitive function and improvements and seizures and AHC attacks, and we track all those things to see. So I don't put everybody, and most, I'll say, most good dietitians, and I say most of your keto dietitians are good ones, because if they stay in this, they really care, because it's really involved. It's a lot, but it's so cool because we see so many people get better. So you don't want to get put in a box to say, oh, you have to do this. And like, no, let's do this. Let's see what's working. Let's evaluate it and make adjustments.
Mm-hmm. She also said, what about G-tube? Do you mean, how do you administer it? The type?
No, what I mean, I'm sorry, it will be better just for me to talk instead of
Sure.
me typing it. Having a higher ratio when you have a G-tube kid, that it's like 99%, it's easier to manage versus a kid that actually eats. So the higher the ratio, my question was, it will be, for me, it's not an issue because she is on the G-tube 99% of her diet. So I just want to know, like, if it will be better cognitive, because we already saw results. Better talking,
potentially. Yeah. So potentially, potentially it's better. Higher is better. I guess I just try to get out of the higher is always better and only better. So when someone's on a G-tube, we very easily can take that formula up to that 4-to-1, and it doesn't bother them. They're not trying to eat all this oil. And so it's very simple. And sometimes we'll do a 4-to-1, say, pretend someone does eat part of their food. We might do a 4-to-1, really high ratio in the G-tube, and then maybe they eat only 2-to-1, like a much lower. It's easier to eat that, so, but yeah, I'm always, let's push it as far as we need to get the most benefit that we can. So yes, if someone's doing well at a 2-to-1, maybe we push to a 4-to-1 because we can. And also it's time on the diet. It really, after some people have a few benefits right in the beginning, after a few weeks, but many people take several months to really see benefit. With epilepsy, we say let's at least wait 3.2 months. So I say 4. That's per literature, 4 months before we make any decisions. But when people are doing better at 4 months, sometimes at 6 months, they're better yet. And at 8 months, they're better yet. And so we really, the more I see this in other conditions, the more I realize the importance of the time as well as the numbers.
And another question, after being on the keto diet, can the kid reject the keto diet? Like my daughter has been in a keto diet for like a year and a half. So I was just wondering if kids can actually, their body can stop rejecting so much fat.
When you say rejected, like not tolerating or it not
correct,
working?
not tolerating. Yes, not tolerating.
I'll say I've had people that sometimes they come up with a problem, but usually we can troubleshoot that. Usually we say sometimes we have to add a pancreatic enzyme or lower the ratio or change the types of fats, or are they constipated, or like what's wrong? Because if they're tolerating it and then suddenly they're not, to me, usually that's something we can find and fix.
What does that mean? I'm not knowledgeable about the pediatric enzyme. Can you give more details?
Wait, I'm not sure what you meant.
Oh,
like
you said that they can
enzyme.
add more enzyme.
Pancreatic enzymes, like someone, like if you've heard of cystic fibrosis, they have to take pancreatic enzymes every single meal to help them digest fat. So sometimes over time, they're not producing enough of that enzyme and in their pancreas, and just taking even 1 or 2 with the meal. It's a little trickier with the G-tube. That's a whole nother story, but those enzymes might help. I've had children that can't gain weight and we realize, they're malabsorbing their fat. And then we give them enzymes and now they start digesting more of the fat and they start gaining weight again. So yeah, there are many things to troubleshoot, which again is why we always ask people, please don't go it alone with keto. Please don't just do it all on your own with no dietitian, with no physician to back you up, because these things can sometimes be very, I'll say easily, but can be fixed and troubleshoot them.
What will be the ideal, well, I guess it's something more for the dietitian, the ideal weight gain during a keto diet for a kid to make.
So I have a cheat sheet. I won't pull it out, but it has, for a child 1 to 4, they should gain this much weight. For a child 5 to 8, this much weight. So I pull out my cheat sheet and I look at their age. And then I also look at, does this child have cerebral palsy? Do they have different things that may impact what's really a good weight gain for them? If their height is, if they're much shorter than usual, then maybe their weight gain is appropriately lower, right? So we're looking at the big picture, not only my cheat sheet, but I use that as a guideline. They're like RDA standards based on, when you take your baby to the doctor, they say, you should gain this much. It's just those same standards that we use as a starting point. It's a good question. So we expect the same growth as any other diet, I guess, is, the point.
I know, but when you have a kid with like a genetic disorder, I guess the doctor has to make the evaluation to see if it's because of the diet or if it's because of the genetic disorder. How do we manage? So it's kind of hard.
And that's very specific to a disorder and we have some, as dietitians, we have some growth charts for very specific disorders as well. We have a CP growth chart. I'm just naming that one because that's what I'm thinking of. But we have different growth charts that we're going to use to evaluate. And we're also going to look at, a child's BMI or their weight for height and say, okay, this is children with this condition have, they are shorter, they are smaller, or some of these kids, they're never going to get much weight on them, right? They may be chronically skinny. That's very typical. So I'm not going to shove them full of calories when every other child with that condition is also thin, right? So it's a balance. It's very much looking at the individual.
Gotcha. Okay, thank you.
Yeah, you're welcome. Great questions. Great questions.
So on
Anybody else?
the adult kids, would it help lose weight?
If someone needs to lose weight, so one thing that people commonly think about keto is they think it's a weight loss diet. And you can lose weight on keto a little easier than on, say, just a regular lower calorie diet, but you have to still take in less than you burn. So if you need to gain weight on keto, you can gain weight on keto with enough calories. And if you need to lose, it's a little easier because your appetite is mildly suppressed. You're not having these blood sugar fluctuations up and down so much. So it's easier to eat a little less. And people find that it's a great weight loss tool. But we don't want people saying, and I've had this so many times, they say, well, I don't want them to do keto because they can't lose any weight. So I think the youngest person I've put on keto is a 5-day-old baby. And you guys know if there's one job for a baby and your child, it's to gain weight, right? If they don't gain weight, everything is wrong. It's a problem. It's a huge problem. So keto is not a weight loss diet. It's just a metabolic state of what kind of energy you're burning. It's a good question, though. I'm glad you brought that up because it's high on a lot of people's minds.
And I have a question because with the keto diet, I know, well, when they're kids, there's more resources, but when they're actually getting older, having a kid on a keto diet, getting older, what are the resources? Like, do they have keto dietitians? Do they have to still do blood work when they get older, as now when they're kids?
Great.
How is that transition?
Question. This is a huge problem, and some of you guys that have adults now with AHC have probably found this. And a lot of conditions you age out. In pediatric neurology, they say bye-bye at 18 or 21 in the different hospitals. They all vary at what point they, let's say, kick you out. And so with keto, the keto dietitians usually have to follow whatever the neurologists are doing. I'm being recorded, but that's okay. I left a long time ago. I actually got in trouble at U of M because I was going to the adult clinic and seeing adults because some of my patients had aged out into adult. And so I'm going over there and I'm still going to see them. And I finally got in trouble for that. And then they finally fixed the problem and they created a position. But a lot of places are having that issue where there's not an adult dietitian to do keto. Then that's where partly what I built my practice on. That's why I'm working with Heather, is because she aged out. She aged out. And so in all honesty, I mean, people end up paying for, sometimes you can find adult programs and I send people when I can find them, but if not, it's usually private pay, unfortunately. And a lot of times insurance isn't taken. So it's a huge problem, but more and more of the programs are working on it. I mean, that's all I can say. Like, it's a very small group of us keto dietitians. Most of us know each other, not all, but a lot of us know each other because there aren't that many of us. And it's a big conversation, and more of them are at least continuing to see their adult patients so they don't age out like Heather's issue. Mm-hmm. Man, good questions. You guys are hitting the hard stuff.
Yeah, I just my concern is like not sure for how long my daughter will be on G-tube and be able to eat by mouth because she's able to, but it's more like a mental thing. But she's on G-tube, but can the insurance cover keto formula after they're once they're adults?
Yep.
So if someone has a G-tube, insurance, knock on wood, I've had one time ever that insurance wouldn't cover, and I don't even know what happened, with it. Like, this can't be that they didn't cover. But I'm going to say globally in general, insurance should always cover a G-tube feeding. And then whether it's keto or not. And then I do like to say, though, if it's safe to orally feed, then by all means, someone who's doing keto, we want to feed as much as they want to eat. It doesn't we don't want it to be only G-tube if we can help it. So if it's safe, we want food going in there for all kinds of reasons, you know, for developmental, for social, for even the swallowing. I've had people say their child's lung function is better when they're eating and using those muscles. It was something I'd never even heard of. And I thought, well, that kind of makes sense. They're swallowing, they're using these muscles that they aren't using as much when they're not eating. So yeah, we want to feed as much as we can, but yes, they'll be covered.
And as a parent, you know, my daughter has a G tube and she's just not been able to chew certain things over her lifetime with the AHC attacks and just all the muscles it takes in your mouth. So we do a combination of G tube feeds and eating. And if there's times where she was going to eat, but she's in an attack, then she gets a G tube blend. And like Denise said, there's several companies that have ketogenic food blends in packets, but we also have recipes to make a G-tube blend for all her needs for the day. And then we just syringe it in her G-tube. So there's a lot of different things you can try, you know, if you have somebody to help you.
I'm super curious, like if you guys want to like raise your, like, I'm curious how many people have kids with G-tubes. Is anybody like, is that like, raise your hand or throw I'm kind of curious if it's a large percentage or not, just because it's, so I'm not necessarily saying a lot. A quick note about that. Yeah. So there are, one thing it's thankfully become really common practice now is what Heather was talking about, are blended feeds where they get the, you know, Bill, they can get the exact same thing. We can blend a steak, we can blend bacon, we can blend flax and chia and all these things and make, you know, you'd have to have what do you call it? What's the fancy, Vitamix or equivalent, you know, really good blender. But we can blend this food down to something that will go through these tubes. And that's amazing. So they can eat, these kids get a healthier diet, or adults, healthier diet than anybody else around. Because we're putting, you know, there's never any question of, are you going to eat your broccoli? Are you going to eat your spinach? Are you going to eat your flax? Nope, it's just going into the blend. And so it's really good for them. And then there is one company that makes a keto whole food blend. And so that is a great option. But if you're doing your own blend, you can vary the foods all the time. You know, that blend's going to be static and the same all the time. And then there are two other, well, they just merged. So it's really only two companies now. But then they have these formulas similar to if anybody has a tube feeding, you know, there's Ensure and Jevity and these other different formulas. I challenge anybody, if you do have anybody on a regular formula, that you just take a look at the container and see what's in there, because you will probably find, if it's not keto, that there's a pretty high proportion of sugar. Sometimes there's as much as a cup of sugar a day in those formulas. So as if you had just poured a cup of sugar on your child's plate. That's what they're getting in some of those formulas. So it's just something to think about. But anyway, so we have formulas that are vegetarian. We have them at different ratios. So this 4-to-1, 3-to-1, 2.5-to-1. And we have them, you know, with dairy, without dairy, with MCT oil, which is helpful for keto, without, and several variations. So we can usually find something that works in a peptide formula that's broken down, so basically pre-digested, so the proteins are broken down. So yeah, lots of options that we can usually find a formula people can tolerate. Okay.
Electrolytes with the waters for kids with on keto, do you recommend? Because I've been having on and off with the dietitian. Some dietitians say yes, but if some of them say no, you don't need it because it has a lot of potassium. Because my daughter does take citrate potassium already. One dietitian said yes, give her electrolytes, and then the other dietitians say no, don't give her electrolytes because she's already citrate potassium.
Oh, well, depending on a formula that someone's on, I mean, if someone's on a blended feed, I'm for sure going to probably going to give them potassium, but we also sometimes we evaluate and we'll put all the foods into something like Chronometer, an app where you can check how much are they getting. And if they're on a formula, standard formula, I can put that into Keto Diet Calculator, which is a program we use, and it will tell me exactly how much potassium they're getting from that standard formula. If they use 5 boxes a day, I know exactly what they're getting. And so at that point, you make decisions on what to add. If you just look at potassium in the blood, that doesn't tell me what they're eating, that they're eating an adequate amount. I'm going to look at what their intake is and sometimes add some. So it depends. It depends what their intake is. Yeah, that's a tough one to get, too detailed. And it's hard if you have two people telling you two different things, you probably need a tiebreaker. And I don't know if I can be a tiebreaker for you without enough details. But yeah, that's a hard one. Let's see. So I'm curious if anybody is anybody, well, again, you guys may or may not want to disclose. Is anybody else on keto that's in the audience today? Oh, there's the kitty.
Yeah. Well, I'm not. My daughter is and has been and Denise, but my daughter Olivia is turning 6 this summer and she's been on it since she was 1. And we love it. We're huge keto fans. She's at an incredibly low ratio, so she's a little bit different. She's more like, I don't know, 1-to-1 because her ketones are she's little, so she makes them easily, but it's been a really good journey with some bumps in the road. It's not super easy, but once you get a rhythm down, it goes really well.
Since you're sharing, Christy, do you want to share any more about what it's done for her AHC? Is that something you feel like sharing?
Yeah, so she started at 1 and we definitely saw a reduction in episodes and severity. And I think the biggest thing we saw over the years was her cognitive ability. Her speech is really amazing. She can speak in full sentences. She can describe her emotions to us. And I think we all know in AHC that's really important. So that was huge. And her energy levels. We've tried to come off keto 3 times, because in the AHC world, when something goes wrong, you try everything. So it's like, oh, maybe she needs to come off this diet. Maybe that will be a miracle. And as we came off, her energy every single time went downhill big time. She would require a couple naps a day, couldn't play as long. And the moment we got back on a good keto ratio, she's zooming around, no nap, and a full 12 hours of sleep. So I think for her, the cognitive part and the energy levels are worth it alone. And of course, any reduction in episodes, it never will for her take them away. And we had to be at peace with that because at first we were like, they're going to go away completely. It never took them away completely, but there was so many other benefits.
I think one thing that's important, in AHC, there's some data for keto. There's not a ton. We'd love to see, prove to me, show me 20 studies, 10 studies that prove, it helps a lot. And just with the number of people that have this condition, and then just you have to have a scientist that wants to study it and build a study and someone to fund it, so sometimes to say, well, there's not enough information, it's not really going to work. Well, that doesn't mean that something's not going to work. It just means that there was not enough money or interest to do a study or enough studies. So I take very seriously reports like that, when people see its improvement. And again, anything neurological is can be impacted by keto. And what's really a thought just went right through my brain and then it left, it exited. Oh my goodness. I'm going to come back to it because it just left. So I'm going to stop.
I do have a question for you though, Denise. Something that's been talked about in the AHC world a little bit recently is a concern about foods high in glutamate and histamine. And I wondered if you could speak about that potentially for other neurological issues, or if you've run into those two items before. We directly see it for Olivia, but she had some genetic testing done to show sensitivity with histamine. So we had to remove high histamine foods. But there's a lot of talk just on the Facebook group and in general about parents reducing histamines and glutamate with success. So I didn't know if you could speak to that.
So I don't know much as far as in the AHC world at all. I connect, like I said, you guys are seeing something, so you know more than me. I will say that, glutamates and protein, and we have that in the cancer space, they're trying to decrease glutamate. So it's interesting for that specifically. And they have glutamate inhibitors, but that are not available. So it's really like, as that comes out, if something ever comes out in the cancer space, maybe it'll be something helpful in the AHC space. I don't know. But when we reduce the protein down, like we do in keto, it depends on how your child or your loved one eats. But a lot of times it's a lower protein diet than people normally eat. And so we've reduced it naturally, and you can reduce it as far as we can go to get down to the RDA for protein and keep that lower. Your body's going to make some glutamate no matter what. You need some, you don't want none. You can't have no glutamate. So so it's an interesting conversation there. And as far as the histamines, I just judge that people come in sometimes and they have histamine issues, and we just avoid those foods, or we're trying to, they're trying to keep everything fresh and, freeze things and not eat leftovers and all that to avoid the histamine. So we definitely can do that within keto space, but I apologize. I can't speak to me knowing what it does or how it might help in combination with keto at all. I just don't know. You stumped me.
Thank you.
Okay. I'm curious if anybody is scared, scared of keto, if there's any issues of safety. I think I found what I was going to say a minute ago, is that if anybody is considering keto, if it's something you've tossed around as a potential to help for your child or loved one, is that there's a very, very long, 100-year-long safety track record with keto for children and adults. And it also was done in adults in the very first studies. And sometimes people think, oh, it's too late, they're an adult, they do this for kids only. That's not true. That's someone who doesn't really know that it was done in epilepsy way back 100 years ago for both kids and adults. So the track record's there. It's been proven safe in all different conditions. There are just a couple of reasons why one wouldn't do keto, and usually that's eked out. There's a short list of conditions where you wouldn't do it. I'm not going to try and name them all off, but just like to say that there's a good safety record, so we don't worry about that. And that's when it's done well and under good clinician care. I see a couple of questions up here.
Yeah,
So should we go to those?
Yeah. How do we know if it is time to add the enzyme?
Oh, the pancreatic enzymes.
Mm-hmm.
That would, if I see someone that has, say, a mucousy or a fatty stool, I add pancreatic enzymes, because that means the fat's not absorbing. Or again, if I had a child that seems, gosh, we're giving plenty of calories, why aren't they gaining weight? I might add enzymes. If someone's, just seemingly for whatever reason not tolerating the diet, I might add enzymes, as in maybe they're nauseated or something. So kind of a few different reasons that we've added them. And there's a whole trick about getting them through a G-tube, and I'd have to look it up. So I'm not going to try and tell you that right now, because they're not, it is like you dissolve them and push them, and there's a trick that I cannot remember. So
another is from Mary. I don't think I'm scared of it, but our hospital, U of M, wants us to do a 2-week stay if we switch our son to keto, which is the concern.
U of M as in University of Michigan?
Uh-huh.
Oh, I can fix that. I got people. Sorry. Okay, I shouldn't say that. I'm recorded. Wow. No, I just had dinner with two of the U of M dietitians the other day, and one of them's one that I worked with when I was there, actually came in while I was there. She's great. So anyway, oh my gosh, that's funny. We just talked about someone they were worried about that was fragile, that they wanted to come in for a long stay. Here's my thought on so with the hospitals when they insist, and U of M also does outpatient initiations. When hospitals tend to get worried about initiations, and they'll say if someone's really fragile, they want to do it safely and in the hospital so they can draw blood a lot. My argument for that, if I have a really fragile child, and again, medically, this is a way bigger conversation, so be cautious with how you take my words. But if someone's fragile, I could take them up on keto over a period of 1 or 2 or 3 months and do this so slowly and so cautiously that they don't even know they're going into ketosis, and so we're not stressing the body. And I feel very strongly about that because, again, let's look at what is stress. I mean, taking a child with AHC into the hospital, I'm sure you guys would all raise your hand and say, goodness gracious, that's probably one of the worst things you could do, right, is go in the hospital. So I think it's also maybe someone who maybe they don't fully understand how traumatic that is for them to go in and have lights and noises and people all the time. So yeah, that's a longer conversation that, and Heather can give you my email. And if you guys, I mean, seriously, if you want to connect, and I can't, in any way make any promises, but I think it's like just I may be able to have a conversation with you privately about things to ask them to, ask why. But that's what I would say is, why could we not do this over 3 months? Why could we not just creep into ketosis? And when we first started doing keto outpatient, we didn't realize that we did it still over a week. And it was terrible. I had a kid at home in a blizzard that needed labs and was taken by ambulance through a blizzard to the hospital. And it was not a good thing because that's what we thought. We only knew we could do it one way. So when you say outpatient, I would challenge them to think of other ways to do it.
Yeah, and I would say along with that, Mary or anyone, if you need some extra support in advocating for what's going to work for your child with AHC and epilepsy, or just AHC, to use us, you call me if I can, encourage them to read about AHC and the difficulties of being in the hospital and things like that. Let me know, because for my daughter Jocelyn, we started at home, and I'll just name drop Cincinnati, but we started at Cincy Children's, but we did it at home. Mm-hmm. So now when we tried it when she was little, when we thought she had epilepsy and we didn't have the AHC diagnosis, they made us go in for a week. But that was way back, 25 years ago. So yeah. Things have changed immensely.
Yeah, it really has evolved, and COVID, we were starting to do some before COVID outpatient, but COVID really necessitated outpatient initiation. So most places are, they're more interested now, but yeah, we can, talk, and that's a conversation. I said I know the outpatient dietitian, but again, the doctor is the one who's going to probably push and dictate that, but I don't mind giving Sam a call. So Adriana, go ahead.
Yes, I actually just want to give my input. Like for me, actually, the neurologist told me, just give me 2 months. If you see results, just give me 2 months. Just try it and have a consultation with a dietitian. We were with the dietitian for 2 hours and completely changed my perspective of keto, because before with all the informations with other doctors, they were putting keto as the worst thing ever that I can do to my kid. So I feel like, I was like, oh, that looks easy. Well, especially for my daughter, because it's G2. But all the concerns that I had, you cannot put cream, you cannot put this cream, you cannot put this toothpaste. I was like, that's horrible. Like they gave me the wrong information. And when I went to the consultation, the dietitian, I was like, no, that's too extreme. Like we don't do that. Like it's not like that. So it is a completely, it's good to just to go to the consultation with the dietitian, write down all the questions that you might have. If people are going to start a diet, and it's a better outcome than just, oh, somebody say this, another dietitian say something different.
Yeah, thank you for that.
Great.
That's a great point. And you know what? I did that. I gave people this huge list of, this toothpaste and that, and really, really nitpicky on all the products, because sometimes it could. I mean, if you rub lotion all over your child, that lotion might throw off ketosis, okay? But most people have tried to relax on some of these tight restrictions. So you definitely still have a variability, just like you do amongst doctors, about what recommendations people might make. But just know that there's some flexibility within that, and we try to be as flexible as we can to, just like we said, we don't want a super high ratio unless we have to, because we want them to, if they're eating, to eat more actual food. So no, that's great to know that they helped you to understand it. And honestly, so you guys just, you guys have spent a lot of time, I'm sure, dealing with the healthcare system. Okay. So if you know anything, that not every doctor knows everything. Guess that, figure that out. Not every dietitian knows everything. And sometimes you have to kiss a few frogs before you find your prince. And so don't be afraid to say, or my husband always, he always tells our kids, the answer is not the answer until it's the answer, or the answer you want. So if you really want to do keto and you're getting pushback, unless there's a legitimate health reason not to, then they should let you. I mean, if there might be reasons not to. We always have to keep that in mind. But by and large, it's safe for most people. There are cautions, but largely it's safe.
Eunice had a question. Are there any concerns with the keto diet and having a short QT, internal heart condition? I don't know if that's been studied yet, but
you know what? Every time when this comes up, and I thought it was long, they're short. Well, we talked about this. Yeah. Oh my gosh, yes, because I did when I came and spoke a year or 2 years ago. I looked this up in depth and I'd have to look it up again because it's not something that's on front and center for me. But if I remember right, there was not a concern. There is some meds cause a long QT interval. There's some issues, and I have one patient that has a long QT. It was the opposite. That's why I remember trying to understand this. But it was not, keto doesn't cause that. And there's never been any evidence that I know of that it exacerbates it. And man, Heather, I know we talked about this at the time.
I know.
Go back and look at those articles, but I remember coming in thinking, no, this is not a reason. I mean, I have to, to relook at the articles, but I recall that saying, to myself and, during that discussion that I wasn't seeing anything there that was solid that would make a concern. But before someone did that, I mean, that's something we could look back up. And I know you shared articles with me, and I'm sure I saved them, and something that we could go deeper in. But
well, and I can even Dr. Landstrom, who spoke at the meeting, and I don't know if you got to meeting because he had to rush out too, but he sees a lot of our population or is going to. So I can ask him if he has a dietitian that's worked with them for any reason that might know more. He just moved to Pennsylvania. Is it CHOP? He's at CHOP.
Oh, okay.
He was in at Duke.
Okay.
April. Oh, go ahead.
Oh, I'm just going to say CHOP is just one of the premier,
Yeah.
long-standing keto institutions, and Duke also. I mean, a good friend of mine is the keto dietitian at Duke, so I mean, those are just great places. So he's within a
Yeah.
groups of assuming he's a neurologist.
No, he's a cardiologist.
Oh, he's a
He's studying
cardiologist.
the short QT. Yeah.
Oh, okay,
Yeah, he's
So,
expert in that.
okay, got it.
April said we've tossed around the idea of keto, but our neurologist requires frequent blood tests on keto. Our son has severe behavioral issues, so we cannot safely get blood work done. Our other hang up is that he loves milk and apples, according to his neuro. He would have to give those up. Our son doesn't have much joys in life, so we hate to take away those small joys.
Oh my
Well, I
God.
just got to say, for a really short parent perspective, is Jocelyn was a chip cookie eating fool before keto, and she loves her pancakes, her cheddar biscuits, all the pizza, So it is hard, but they do adapt.
They
Amazingly.
find other things. So,
Yeah.
and I apologize because the blood work came up earlier and I forgot to answer that. So typical blood work on keto is pre-diet, a set of labs, at 3 to 4 months, a set of labs, every 3 to 4 months the first year. And then when you get into the second year, and it's assuming you continue on keto, we can stretch it out to every 6 months, I mean, depending, I don't like going much more than 6 months on a child, really. So that's one thing as far as labs. Now, if someone has an issue, and I'm, in a different boat in private practice, I get to make my own decision on, I'll take the risk if someone can't get labs done right now, and are they safe? Do we know they're otherwise safe and healthy? With a child, I might not, it depends. If you could do a finger poke, they don't do it in this country. I don't know why, but it's a money thing, I'm sure, but you can get electrolytes checked, by a finger poke. And the odds of them having a high cholesterol are slim. And are we really that worried about it, right? I've only had one person ever I didn't put on keto because their cholesterol was 500. Okay, so we can rule out some things. Iron, we're going to supplement anyway. We could cover the bases on iron. Carnitine, we're very worried about. If I can't get labs, I supplement carnitine just prophylactically. So there are things that can be done in the absence of labs, but that is the standard procedure. But I don't know, can he ever get labs? Can you negotiate that, we do labs twice a year only, and maybe that electrolyte poke if needed, I mean, that is a big issue, but it's a treatment. Are we going to not do this treatment if it would be helpful? Yeah, I don't know. I don't know I don't know which one's April because I don't see an April on the screen. Or did she go?
She might have just left. She was
left.
on.
Okay.
Yeah. Christy said they started keto at home. Boston Children's went nice and slow. Adriana asked, what are your thoughts about keto conference in Africa this year?
I'm going. Yeah. Well, it's not this year, it's next year, right? You mean in South Africa,
Yes, the one in South Africa. I just want to. I went one time, only the one in San Diego, but I don't know about the. I was only for only one day because I was not able to attend the whole.
Yeah.
I think it was 3 days. So I just want to see if there's any benefits or that I can learn more about it and trying to understand. For me, it's more about trying to understand and read all the lab work, be able to comprehend and get a better picture of how to read the labs or what concerns when I'm actually looking at the labs.
Yeah, I feel so. One, I mean, I go to all those conferences because that's my colleagues and I want to see them all. And, and sometimes some of the meetings are great and some of them are like, oh my gosh, this is the most boring talk about research I've ever seen, So I think to go for the intent that you're going, would want to go. I wouldn't. I would do learn, and this is going to sound totally self-serving, but I'm going to say it anyway. We have a class that it's called Keto Mastery, and it's aimed at dietitians. Okay, it's aimed at dietitians and doctors to learn about keto. We have a foundational course, but we decided when we did it to not limit it to doctors and dietitians, to not say, no, you have to be medical, because we know there are a lot of people that, I mean, you can go on the internet and you can search anything, right? And you really don't always know if it's good information. So I thought, well, why would I not leave my information for anybody and instead of limit it to professionals? So there is that, and there are other, probably other courses and things as well. And there are continuing ed things that you can take. If you look under the companies, Nutricia is one. It's spelled with a C, Nutricia. And then Cambrook is the other one. It's Cambrooke, and then Ajinomoto. So those are the two companies that sell keto formulas, and they do keto programming also. So you can get on their websites and look for continuing ed units. See if you can get in there. I don't know if you can get in there not being a dietitian. So, but you could try to do also education that way and get into some of their, they do free webinars and things all the time. But again, sometimes they limit those to clinicians. So, but I feel like South Africa is a long way to go, a lot of money to spend when you say, oh, I want to learn about labs. I mean, you could pay someone in my company for a 1 hour call and save a lot of money than traveling there and just ask a million questions, So, and I apologize, Heather. I'm trying not to I'm not trying to really promote, but I can't not say it.
Yeah.
All right. Thank you for the information. Just trying to see where I can gather more accurate information instead of just searching and not knowing if what I'm reading is actually good information or not, and then getting confused.
Absolutely. But I've never been to South Africa, and I absolutely plan to go. My daughter is there right now, and so I can't wait to see it. It's supposed to be a beautiful place. So on that end, I highly recommend it. I mean, I'm not saying it's a good conference. It always is. It's just a lot of money for when you have some very specific things you want to learn, and they might not even talk about that.
Joe asked, I came a bit late to the webinar, so I'm sorry to have you repeat if you have already touched on this. Are there measurable success rate that children with AHC can improve their symptoms being on a keto diet? That's the first part. Hold on. My computer. For a specific amount of time, and then when they slowly transmit into a more varied diet, that they stay with less severe symptoms? And how long can young children safely stay on keto if you see benefit from the diet?
Okay, I'll remember to answer all these. So the first one, and I apologize that I didn't brush up on numbers. There's a little bit of research in AHC, and I don't know. Heather, do you know it off the top of your head?
I don't
have it in my head.
They kind of got numbers from different neurologists or dietitians. It wasn't like a study and here's this many AHC in one place. And I don't have that. I know it was coming out with just what they gathered, but I don't know.
Yeah. So, and that might be an article you could pull and maybe share with the group. So, I mean, and we know we've seen enough benefit, in the people we worked with that we feel confident to say, hey, this is, a good idea to try. And what I usually tell people is, it's that I would try for a good 3 months, if not 4. I mean, I really hate when people stop before 4 months, because it takes some time. When you talk about doing keto and then going off, I mean, Christy has already given us the example of they've tried, because it can be hard, and it can be, different people adjust, easier, but they've tried 3 different times to come off, and each time felt like, wow, our daughter does better on this than off this. We're going to continue it. And depending on someone's condition, we see in epilepsy, sometimes kids, and I know epilepsy versus AHC, but we sometimes see brain healing. okay, where enough things change in the brain, they do keto for 2 years is kind of the standard. They take them off the diet, and about half of them will maintain their seizure control. Say they were seizure free, half of them stay seizure free. But a lot of them might be, okay, I'm down to 2 seizures a month versus 10. Okay, well, then they maintain that. The other half of them get worse again. In epilepsy, there are a million different causes for epilepsy. So it's really, the data is really so hard to interpret because there are so many causes. We're seeing in some other conditions where we use keto, again, neurological conditions, brain energy conditions, like let's take someone with bipolar. I know people who with bipolar disorder have done keto for a year or two, transitioned off keto, and their symptoms don't return. Okay, a few. This is really small, and we're going to have better research in a few years. But it's, again, we're changing brain chemistry. For some people, maybe it lasts. And then for some people, it doesn't. In migraines, this is super cool. And if someone said to me, and if you know anybody with migraines, keto is where it's at. If you ask me what's the best thing someone should always try for keto, I'd say migraines, or try. And they already have a consensus guideline, and they say with migraines, hey, do it for a year or two, and then go ahead and quit. And they have exact number, they have specific goal, like guidelines saying it, like you're 70% likely to maintain migraine freedom for a year. If you do it for this long, you're this likely. And then they're just like, hey, if a year or two your migraines come back, just go back on keto. I mean, they're just, that's what they're saying in migraines. Like, this is awesome because, maybe people can do this if they can cycle back and forth a little bit. And I think that's what, in all reality, sometimes in different conditions, most people aren't doing this perfectly, right? When you have a parent instituting the diet for someone, it's very often perfect or near perfect. When you have a regular old human trying to control their own food, it's rarely perfect. So, yeah, I don't know. Did I answer all 3 of the questions in there? I'm not sure. I know.
I think so.
You get past 2 and I forget.
I think that was it.
Okay.
I have a quick question, Denise. How do you focus on one of the biggest things I hear from other people about keto is varying their gut health and making sure you get the right things in your gut. And if you don't do carbs, you won't have that. It's a lot of the feedback I get. Do you get that question a lot? And if so, what's your response to that?
I don't really get it a lot because, I mean, like questions like as in someone trying to say, oh, you shouldn't do it because of that. Because, I mean, by the time people get to us, on a honest, like a fee for service, they're like, they've made up their mind.
Yeah.
It's not a debate anymore. But we try to do, a whole food keto. We don't want keto. I mean, we still allow if necessary, but we don't want a bunch of keto bars and keto this and keto, treats out of the grocery store. We want meat and vegetables and oil and butter, right? We want whole foods. And so we get as much vegetables in there as we can. And I dare say that a lot of people, when they're eating keto, even if they're only eating, let's say 20, 30 grams of carb a day, which that's the equivalent of 1 to 2 pieces of bread. Okay. So let's say they're eating 30 grams of carb, but 30 grams of carb might mean you eat, and I've got a slide for this and I wish I could pull it quick. It might mean I eat 2 cups of kale, cup of Brussels sprouts, a cup of strawberries, some cucumbers and some tomatoes and some lettuce, right? All these things that I eat. And I dare say if your kid had Cheerios this morning, a sandwich and a piece of fruit for lunch, and spaghetti for dinner, that the one over here eating 30 grams of carb had a much more wholesome diet than the one that had a typical American diet. And not that everybody eats that way, but so you have to be, and you have to be very intentional about those carbs, because if you say, well, they're just going to eat applesauce and that's their, 30 grams of carb. Well, no, that's going to be a terrible diet if all they eat is applesauce.
That's perfect. Yeah. And is there certain things I know in the past, like that you have to really be careful with, like maintaining fiber and other things with keto?
So the fiber, yeah, to me, fiber is really up for debate, and I think because the guidelines for fiber are probably set too high. Maybe, maybe not. Um, we see kids that have 2 to 5 grams of carb a day that stool just fine, they poop fine, and their gut seems fine, and they're not having seizures or they're not having episodes. And who am I to say what does it mean? One thing I know, and when you start, and I don't mind being argumentative. It's kind of in my DNA. It's kind of fun. So when you start saying, and I know you weren't arguing, okay, but I'm just like devil's advocate, okay? When you say, well, that's not good, and you should have this, and you need X number of this, and you need the X number of that. I'm like, well, what about Keppra? How much Keppra is required, like per RDA? How much Depakote should a person have per day? What's good for them? When you start looking at other treatments and what's good for us and not good for us, dear God, it all goes out the window when we start having, and I'm not against meds, but if you're going to make this huge case that everything has to be perfect, then where do the meds and the side effects come in? Then to me, it all goes out of the water at that point. Like no holds barred now. If we're gonna put that in there, then you can't tell me that I have to make this perfectly, because if life was perfect, we wouldn't be having these freaking AHC episodes then, right? Would we? So here we are. Here we are. We can't do what we wish we could do.
Yeah, perfect.
So.
I was gonna kind of play devil's advocate because a lot of my journey when I worked with you was that family would say something, the doctor would say something, oh, how are you getting your microbiome? Like your microbiome is going to be messed up. How are you getting fiber intake? And the more that I listened to them, the more constipated Olivia would be. Just being on keto, she was able to have 2 bowel movements a day, and she still does to today. But anytime I let someone kind of in and change my mind and had their own perception of keto, it really went south. So I just wanted to express to parents too, it's really important that you're not so concerned about those items and you're just concerned about the healthy. And Olivia is on a whole foods keto, so she doesn't have any of the artificial stuff. It really is all whole food. And that's what's worked for her. But I wanted to play devil's advocate because I dealt with a lot of that through the years.
Yeah, and that's hard too, because family can be either your best help or your worst enemy. And I know you said you had a lot of that, and it's really, you do the best you can, and you find out like who's on my side. I'm drawing a line here, and I need to know who's gonna help me. Who's gonna give this a shot, and you guys, and people have tried. I'm sure with AHC, you try different things, and maybe people are like, oh, you're trying one more thing. Like, okay, but are you with me or not? Because of course I'm going to try one more thing. So
Thank you.
Any other questions? Well, you want to wrap up, Denise? Is there anything else you would like to add? Or
I want to see if there's anything, we kind of talked about some of these different things before we got on, and I feel like we covered a lot of that, because hospital versus outpatient, I think, was a topic we wanted to cover. I think we hit that. The formulas, batching foods. I think maybe one of the biggest things is sometimes people think, oh, I just couldn't do it. I'm too busy. I'm too whatever. Oh, I know we didn't hit. We were talking about, and I don't know if she's still on here, about the different foods that I like, the apples and the milk. And you kind of addressed that, saying that we try, we do different things. And it's hard, but I know. And so, because this is huge, because we see that, I hear this, I've heard this so many times, and I really do take it to heart, where people say food is one of their only pleasures. Okay. And I'm kind of a crybaby, so I kind of want to cry saying that. And you're saying taking that away. But if we're giving something in return, it's not a comparison. It just doesn't even compare. If they had 25% less attacks, would it be worth it? Or 50%? Or if the intensity was 50% less, would it be worth not having that once a day apple? I don't know. And then we find something else that's fun that we put there. So even though we are taking something away, we're giving something back if it works. And it's just a trial to see if it works. We're not saying, oh, let's do this forever. You're saying, let's try this for 3-4 months, see if it helps. And then if it doesn't, then you can also check it off the list and say, you know what, we tried that. But I'll say too, if you try keto, a pet peeve of mine is when people try keto for just a few weeks and then say it doesn't work. Please don't say you tried it if you didn't do it for 3 or 4 months in good ketosis with measurable ketones that you know they were high enough. So that's one thing. And then, yeah, you've got to give it time to see. But it's a tough decision. You want to be really ready. I mean, you don't want to just rush into it. Most people, if you rush into it, it's too easy to rush out of it. You want to give it some time. But yeah, I mean, I appreciate you guys jumping on here and all the great questions. It's a lot, and you know, and Heather's a great resource for you guys, and well, Christy too. You know, they know how this goes. So I'm glad that they're there for you guys to reach out to.
Thank you, Denise. I appreciate it. And thanks everyone for
Right.
joining. I put my email in the chat if anyone needs any support or more information. So thank you, everyone.
Okay.
Have a
Thank
good day.
you.
Thank you.
Bye-bye.
Bye-bye.
Bye.